Welcome to the Rocky Mountain MS Center's webinar series, Maximizing Lifelong Brain Health in MS. Today's topic is progressive MS and palliative care. This presentation features Dr. Robert Gross and Dr. Christina Vaughn. Dr. Gross sees patients with MS and related disorders of the central nervous system. He divides his time between patient care, teaching, and clinical research. Research interests include optimization of treatments in MS. Dr. Vaughn is a neurologist and palliative care specialist. In this webinar, she will give an overview of what palliative care is and how this approach can be particularly useful in the management of MS and in optimization of quality of life. We would like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Celgene, and Novartis. This webinar is scheduled for 1 hour. The first 45 minutes will be the presentation. If you missed something on a slide, we will be archiving this webinar along with the slides on our website at www.mscenter.org, so you can replay it at any time. We'll reserve approximately 15 minutes at the end to answer questions from the audience. You can submit questions at any time during the hour by typing them into the chat window on your screen. We'll answer as many questions as time allows. With that, we'll turn it over to Dr. Gross.
Good afternoon, and thank you for the opportunity to talk about progressive MS, which is a super important topic. So let's get started. Here we go. I like to start with this slide, about the expanded disability status scale. This is the most commonly used disability metric that we have in multiple sclerosis. And as you can see, it starts with 0 on the left-hand side, where somebody is basically completely normal. And then it, as you go from 1 to 2, 3, 4, 5, 6, etc., you start to accrue disability, minimal, then moderate. And then at a 6, people are requiring a cane to get around. By 7, they're in a wheelchair, and then more advanced disease beyond that. What's interesting to note about this scale is that one is people kind of assume that it's a linear scale. For instance, like 4 is 4 times as bad as 1, but that's not really the case. 4 is not 4 times as bad as 1. And then a kind of a related misconception that people have about this scale and about MS in general is that you're going to progress kind of uniformly from no disability onward to more disability, and that's also not really the case. You can, for instance, go from a 0 on the scale to a 3, and then back down to a 1, and up to a 4. And we see these fluctuations commonly in the relapsing phase of the disease. Once people get in the progressive phase of the disease, there's less of that kind of fluctuation, and what we typically see is more of this very slow, insidious decline, typically over months to years. And this is a chart of kind of how MS changes over time. We can see on the left-hand side, this is what happens in the earlier relapsing remitting phase of disease, and then on the right-hand side is the secondary progressive phase of disease. At the very bottom, you can see that the relapsing remitting MS is more dominated by this inflammation in yellow. And when you say inflammation, that's really when people talk about MS as an autoimmune disease. That's what we're referring to. It's your immune cells, for whatever reason, inappropriately targeting the nervous system and causing damage there in the brain and spine. And we can see that damage on MRIs, for instance, on the left-hand side in the blue. Let's see. You can see there's what is GD, that is GAD enhancement. So those are active lesions on the MRI, and then above that, just normal lesions on the MRI. And you can see that they start right here at the beginning of the disease, and perhaps even before you have your first neurological symptoms, they're starting. And that's the most overt sign that we have that there's inflammation going on in the brain. And with that, we see in the red these relapses and remissions in terms of the disability in the relapsing remitting phase. And then once we get to this progressive phase, the relapses kind of start to become fewer, and it becomes more this just kind of deterioration over time. And throughout this time, what we're seeing is that brain volume is diminishing, and we'll come back to that because that's a very important idea. So here you can see the kind of usual brain lesions that we see when we look at an MRI and you come to your appointment, and these really represent those kind of inflammatory plaques that people get with MS. And so we're very good at kind of identifying these, quantifying these, but they only tell part of the story. And the other part of the story that's very important is this brain atrophy. Atrophy or loss of brain tissue, we're realizing is an increasingly important part of the disease. And we all, even those without MS, everybody is losing brain tissue over time. But we know that people with MS, the rate of brain tissue loss is accelerated. And we know that it actually starts very early in the disease course, this loss of brain tissue, even at that first, the CIS, or the first inflammatory relapse, or perhaps even before that, we're seeing loss of brain tissue at accelerated rates. And it proceeds throughout the course of the disease. And so why is this important? Well, I like to think of MS in terms of this model. This is was proposed recently by a former mentor of mine, and this envisions MS kind of like a swimming pool. It's called a topographical model of MS. And what this is you imagine the nervous system as a swimming pool, and you have shallow ends and deep ends. The shallow ends over here, like the optic nerve and the spinal cord, those are areas that are going to be more sensitive to some kind of damage or insult. And then towards the deep end, you have these areas that are like in the deep central parts of the brain where people can have these lesions and they don't really feel them. And so what happens in MS is you get these plaques, which are represented here by these peaks that are coming off the bottom of the pool. And so you have a relapse, you get a peak that comes off the bottom of the pool. It goes above the water surface, and it becomes, with the water surface here is the clinical threshold. So above the surface, you're actually feeling symptoms, okay? And then you get all of these, depending on where you are in the disease process, you can have lots of different plaques or peaks coming off of the bottom. Some of them will be down here below the surface, so that they're not clinically evident, and some of them will be above the surface, in which case they're represented as kind of these continuous symptoms that somebody might have. And what happens with MS, and in particular with SPMS, and SPMS is represented down here on these graphs by D and E, what we see is that the peaks you might not be getting more peaks, but what you are getting is that the water level starts to decline, and so those peaks that were previously there, or pre-existing damage that we can see in the brain from those lesions, become more manifest as the water level goes down. And so that's a very important concept, and I like the way you can kind of envision that with this swimming pool. So now we're going to move into talking about some of the different treatments that we have for progressive MS, and these are immune-based treatments. So what you'll notice is that MS actually has many, over a dozen immune-based treatments, but most of them were studied in progressive MS and were not successful. In other words, they didn't slow down the progression. But now we have at least one, the first one, ocrelizumab, which is approved to treat progressive MS and slow the progression down. We have a very similar medicine in the same class of drug called rituximab, which is much older. It doesn't carry an FDA approval for MS, but because they're so similar, we will often use it in place of ocrelizumab depending on the situation. And then finally, we have another medicine called siponimod. it is not yet approved to treat MS, but hopefully will be in the next few months. And it is related to an existing MS medication called fingolimod or Gilenya. So it is a pill, whereas the first two are IV infusions. So to look at kind of how, why these ended up being approved and why they're effective, this first with ocrelizumab, there was a study just a few years ago now in primary progressive MS that looked at ocrelizumab compared to placebo. And what they were measuring was the probability that somebody was going to get worse over time. And what you can see in this graph here is that in both arms, both the treatment arm and the placebo arm, people did get worse. But you can see that there is a little divide between the placebo arm and the ocrelizumab arm favoring treatment. And so you can say that ocrelizumab very modestly slowed the rate of progression in people with primary progressive MS. But that was considered a positive study, and that's the reason why ocrelizumab is now approved for the treatment of primary progressive MS. But we dove a little deeper into that study, and looking specifically at MRIs, what we noticed is that on the left graph here we have the number of new lesions, and on the right graph we have brain volume. So ocrelizumab, because it works on the kind of autoimmune aspect of the disease, it's very good at preventing new lesions or those peaks that are emanating off the bottom of the pool. So you can see there's a big difference between the number of lesions that people would get on ocrelizumab versus placebo. Ocrelizumab basically shuts off all new lesion formation. On the other hand, if you look at brain volume, there was just a very little difference between the two arms in terms of the rate of brain volume loss. And that's an important point. So let's move on to the next drug, which is siponimod. So siponimod is, as I said, it's an oral medicine that's very similar to Gilenya, which is already existing. And again, what you can see is that this is looking at the accumulation of disability. And the siponimod arm is the one here in blue, and the placebo arm is here in red. And again, what you can see is that there is, between the two arms, is a very slight decrease in the rate of disease progression in the treatment arm versus the placebo. So 21% less likelihood of progressing with, in this case, secondary progressive MS, whereas ocrelizumab was studied with primary progressive MS. But a lot of people consider those two diseases to be pretty much the same thing, at least in terms of why people get worse over time. And then again, looking at the actual MRIs in this study, we can see that on the left, the number of lesions that happened with the siponimod medicine was vastly less than the number of new lesions that we saw in the placebo arm, because again, siponimod, like ocrelizumab, is very good at turning off the autoimmune part of the disease. But the degenerative part of the disease, as represented by the amount of brain volume loss here, there, siponimod again only showed a pretty modest benefit. In fact, if I'm reading this right, siponimod here actually, okay, yeah, so more brain volume loss here in the red. So that was the placebo. So siponimod, again, we see that it was a very mild difference in terms of slowing the rate of brain volume loss. Moving on to the next slide. So those are kind of the traditional traditional and newer immunotherapies in MS. And I think that the reason that we're only seeing this kind of very modest benefit in terms of slowing the progression of progressive MS is that we're capturing people in this red zone, this red circular zone here. So it's kind of right around the time that people are transitioning from a more inflammatory state to a more degenerative state. And the inflammatory state, as I've said, that's where our drugs like ocrelizumab are very, very effective at shutting down new lesion formation, at turning off relapses. Our drugs are very, very effective at that, and that's why they work very well in the relapsing remitting phase, but they work less well in the progressive phase, because less of it has to do with this kind of overt inflammation, and more of it has to do with this, what we'll call neurodegeneration. Now, degeneration is something that is not, first of all, is not specific to MS. We see that in all sorts of other neurological diseases like Alzheimer's disease and Parkinson's disease and so forth. And in the case of MS, we know that it involves, as I've said, brain volume loss. And what we also know is that it has to do with a more widespread or diffuse changes that are occurring, even outside of those plaques that you can see on the MRI. So in the so-called normal appearing white matter, we know that there are structural changes there that are preventing the nerves from firing efficiently. And in fact, that might even be what underlies one of the most common symptoms in MS, which is fatigue. There's not one particular lesion or something that I can point to. Somebody says, I've got fatigue, what is causing that? But we think of it as a kind of a more diffuse or widespread process, and in all likelihood, it's happening in those parts of the brain where the MRI just looks normal, but it's in fact not normal. And the other things that we know are happening in the degenerative phase there's an abnormality in terms of energy production, even on a cellular level. So things like the parts of the cells that produce the energy, the mitochondria, are dysfunctional. And that's probably in part why we're seeing nerves and the nerve connections, the axons, why they tend to disappear and die, and why we get this brain volume loss. But it's not just the nerves that are the problem, it's also all the other cells in the brain. So unlike in this relapsing phase where the problem seems mostly to be with those invading immune cells that are targeting the brain for destruction, in the degenerative phase, it actually seems to be more those native brain cells themselves, the nerves, the microglia, the astrocytes. They all seem to be misbehaving in some way, and that's a lot of probably what's driving this slow decline that we see in progressive MS. So let's talk about a few other drugs that have been studied in progressive MS. Now, these are not what we would consider immunotherapies, in the sense that we don't think they're acting on that adaptive immune system like the other drugs that I mentioned before, but they may have some benefit in terms of progressive MS, and I'll explain each one of them individually. There's high-dose simvastatin, ibutilast, and biotin. So first, high-dose simvastatin. So this was a study from a few years ago from England where they looked at simvastatin, which is a cholesterol-lowering medicine, but they looked at it in a group of patients, a mixed group of patients with primary and secondary progressive MS. And what they found is over this 2-year study that the simvastatin group in the light blue, they actually had a reduced level of brain volume loss compared to the placebo arm. It was actually much greater than we've seen with ocrelizumab or we've seen with any of these other immune-based treatments. It was 43% reduction in the amount of brain volume loss with this drug. It wasn't given in the doses that we'll typically use it for cholesterol lowering. It was actually at a much higher dose, at 80 milligram dose. But regardless, it did show this benefit in this study. So moving on, a different medicine, ibutilast. This is a medicine. It's called a phosphodiesterase inhibitor. It's approved to treat asthma and some other conditions. But again, it was studied more recently in a mixed group of primary and secondary progressive MS patients. And what they found is, again, a near 50% decrease in the rate of brain volume loss in the ibutilast arm as opposed to the placebo arm. So here, again, we're seeing that we're not targeting the formation of lesions themselves. We're more targeting that water level and trying to slow the rate of that water level loss from the swimming pool. And finally, there's this other drug that's also considered experimental called biotin. Now, biotin is actually a B vitamin, at least B7, and it is was studied in a French study now 3 or 4 years ago now, where they looked at again a mixed group of primary and secondary progressive MS patients, and they found that in the group that got this medicine, the high dose biotin, that people not only didn't progress, but a certain percentage of them, nearly 13%, actually showed some improvement in terms of their disease. And so that was really kind of surprising because nobody had even really looked at improvement seriously before. It was mostly just trying to prevent progression. But here they showed actual improvement in people getting this medicine versus the placebo arm where nobody showed any improvement and they just continued their kind of steady decline. And then in the extension phases, what they did was they switched people over who had been on the placebo over to the drug arm, and you can see that over time, more and more of those people who originally started on placebo and then got switched to the drug, some of them too also now started to show some clinical improvement from their baseline. So that was really actually encouraging. But this is still considered an experimental treatment, and in fact, we're currently at the university here involved in a multi-center trial, again placebo-controlled, to try to replicate these findings and see is this actually a drug that can be used successfully in progressive MS patients. And if so, then this will become a part of the standard treatment for progressive MS. But stay tuned. So I think that might be my, okay, and then this is the last slide here, and this is just looking at kind of what some of the possibilities are as to why biotin might work if it does indeed work in progressive MS. And the thought here is that maybe it is related to biotin being used as a factor, a cofactor in some of the energy production that occurs on a cellular level. And that, as I've mentioned before, is one of the problems in MS in general is that the production of energy is altered, is changed. And so if you can boost energy production with, say, biotin, maybe that will actually cause an overall benefit. So with that, I'd like to introduce Dr. Vaughn again. So she is a colleague of mine at the Department of Neurology here, and what she's going to talk to you guys about is palliative care, which is I'll let her kind of tell you what all that entails, but it might be a little bit different from what you previously thought, and what really is a key point here is that with MS, and particularly with progressive MS, we have I guess really just with progressive MS, we have fairly limited tools in our ability to kind of alter the disease course once the kind of water level has declined and once you have those peaks on the bottom of the pool. We're not really adding water back to the pool yet. We're not scraping those peaks off of the bottom of the pool. So that damage is done, is there. And so at this point, there's relatively little that changes the overall course of the disease, but that's not to say we can't do anything. In fact, we can actually do quite a lot, and what we can do is actually target the particular symptoms that a person with progressive MS has, whatever those symptoms may be. So for instance, if they have spasticity, if they have pain, if they have cognitive impairment, fatigue, limited mobility, imbalance, you name it, all of those symptoms we can potentially target with specific treatments, either medications or other interventions. And that's where it becomes very important to have a kind of a more team approach, a collaborative approach, where we can kind of all help contribute to the care of the patient with MS. And in fact, actually, we've seen that quality of life can significantly improve with this disease. So with that, I'll turn it over to Dr. Vaughn.
Thank you so much, Dr. Gross, and thanks for the opportunity to speak with you today. It's a real pleasure for me. So when I'm giving palliative talks, I like to start with this quote from one of the influential historical figures in medicine, Sir William Osler, who said, "To cure sometimes, to relieve often, and to comfort always," reminding us that in medicine, we can't yet cure everything or even always relieve symptoms, but we definitely can always comfort. But my goal in palliative care is to do the last two, certainly, to relieve and comfort. So my objectives are threefold. First, I'd like to demystify palliative care. As my colleague alluded to, sometimes people think they might have an understanding of what palliative care is, but in fact really are missing the mark or perhaps haven't even heard about palliative care. Secondly, I'd like to explain why MS fits so well into the palliative care approach. And then lastly, I'm going to review some symptoms in MS and really make a special emphasis on pain, which is sometimes overlooked in our neurologic diseases. So let's get started. With palliative care, the word palliative actually comes from the word which means to cloak. In Latin, the word is palliare, and it means to cloak. And the idea is there is that you're sort of cloaked with comfort. It's supposed to be a focus on quality of life. Palliative care is a medical specialty. It's relatively new in the U.S. as far as different medical specialties go. And you can also think of it as an approach to care, where we, again, focus on quality of life with a goal to improve quality of life of patients, but not just patients, but also of families, whoever's close to the patient, because we realize, and you're well aware, that these kinds of diagnoses like MS affect not just the patient, but the family and those close to them. And so palliative care can be applied to any serious illness, neurologic or otherwise. And we like for it to be team-based when possible, as Dr. Gross alluded to. So if you think about palliative care as perhaps an umbrella involved in the care of somebody with some sort of chronic, in this case MS, serious, sometimes life-limiting disease, certainly someone who's receiving a palliative care approach can also continue to receive active treatment, whatever that is, as well as aggressive symptom management, kind of hand in hand. We also like to talk about advanced care planning in palliative care, and that means talking about future planning. Should anything unexpected happen medically, what the patient would or wouldn't want. And that's not unique to MS at all. That applies to all conditions, and frankly, all of us, regardless of diagnosis, should have an advanced care plan in place, so that's something we highlight. And again, focusing on quality of life. We like to walk the journey with patients through their illness, however long or short that is, until whenever end of life happens. And so while it's not emphasized, end of life care can be part of palliative care. So we approach different diseases and MS from a team when possible. So here at the university, we have a neuropalliative care clinic that includes the neurologist, the palliative care neurologist, in addition to a social worker, a nurse, a spiritual care counselor, or a chaplain, and certainly the family is part of the care team, with the idea that the patient is in the center, supported by all of these different disciplines and people. So we approach quality of life looking at the physical, the social, and the psychological and spiritual domains, trying to support people from all of those directions, and that's really the essence of what we're trying to accomplish in palliative care. So let's be specific and talk about MS and quality of life. We like to throw around this phrase, quality of life. What is it really? Well, one way of describing quality of life is an individual's perception of life in the context of the culture and value system they live in, as well as in relation to their own goals, their expectations, their standards, and their concerns. And so when we meet with patients in a palliative care setting, we like to highlight what their goals of care are and talk about expectations. You know, what are you expecting from this treatment, from this MS treatment? It's important to make sure we're on the same page, because sometimes if people aren't tuned into what the possible outcomes or benefits are, they might be let down. So we try and make sure we're all on the same page with respect to expectations. And we know that MS can affect a variety of different aspects of life, right? It can affect someone's ability to work, to pursue leisurely activities, and to complete activities of daily living. And when it comes to what really affects quality of life in MS, A recent study in 2018 found that when they asked physicians or clinicians, what do you think quality of life is most affected by in MS, physicians and clinicians naturally said physical aspects, the physical symptoms. Whereas when patients were asked, they replied a bit differently, saying, issues around vitality, pain, as well as general emotional and mental health. Those things really fed into what affected quality of life in MS. And I'm not surprised to hear that because we know that these diseases like MS are a lot more than just the physical symptoms. And so I give for you on this slide a list of all sorts of possible symptoms that can affect people who have MS. Certainly not everyone gets all of these symptoms and to different extents, and it's quite variable. But look at that variety of different symptom types. They can be categorized as physical, certainly, emotional and cognitive, and kind of a catch-all I'm calling invisible symptoms. And so what I'd like to do is go through each of these domains and highlight several of the symptoms and how we might address that in a more palliative care setting. So for the physical, let's talk first about balance problems, and I've kind of grouped them together with mobility and walking issues and spasticity, which means stiffness of the muscles. And so these issues can occur certainly in MS, and one of the things we like to do is assess somebody's environment or ask them, what their living situation is like and try and make sure that things are safe at home. So maintaining a safe environment is one of the things we certainly talk about, and trying to optimize independence. Certainly if that's a top priority for the patient, we make it a top priority as well. Thinking about different ways to maintain independence despite balance problems, mobility issues, and spasticity. Physical therapy, we're all huge fans of physical therapy as much as possible to have one-on-one interaction with a physical therapist, focusing on stretching, mobility, balance, etc. We can talk about energy management practices. As Dr. Gross mentioned and discussed, fatigue can be a huge issue in MS, and so thinking about ways to conserve energy in the face of mobility trouble can be important. Thinking about walking aids, canes, walking sticks, whatever it is. Even bracing can sometimes help with these issues. Botulinum toxin or Botox injections can sometimes be helpful, particularly in the case of spasticity or tight muscles. As you may know, Botox or botulinum toxin is a medicine, or it's a toxin really, but it's used in the medical world to relax, loosen, or weaken muscles to help when they're tight or stiff, and sometimes that can be useful as well. And then certain medications can be tried for spasticity sometimes. We don't have good medications that really target balance, because if you think about it, balance involves many things, whether it's weakness, knowing where your body is in space, sensation, etc. But we can try and come at it from a few other directions. Other physical symptoms I've grouped together could include bladder dysfunction, bowel problems, or sexual dysfunction. When we're dealing with any of these complaints or symptoms, we think about possible behavioral modification techniques. We don't always jump to medications first and think whether or not somebody perhaps with a bladder issue could consider emptying their bladder on a schedule. If they don't remember to urinate and it gets to the point where they have accidents, perhaps making a point to urinate every 2 hours, for example, might be a strategy to deal with that kind of issue. Bowel problems such as perhaps constipation is something we can aggressively manage with lifestyle changes, with dietary recommendations, with supplements, etc. And then with sexual dysfunction, one important thing we can check in with there is an assessment of mood. When people have MS and also have depression, that can certainly have widespread effects, including sexual dysfunction. So sometimes an assessment and treatment of mood can actually have a great impact on that as well. And there are certainly medications that could be considered there. Back to bladder dysfunction, another thing to always consider or have on our radar is screening for urinary tract infections to make sure that's not clouding the picture. And there's plenty of things we can try and handle within a neurology or a palliative care clinic, but sometimes it does involve a urologist, a specialist, to assess. And in more severe cases, the consideration of intermittent catheterizing to empty the bladder, or if more permanent catheterization is needed, a suprapubic catheter can be considered with the help of a urologist. Other physical symptoms in MS could include speech and swallowing difficulties. This, again, is a hard thing to treat with medications, but certainly we have access to specialized speech pathologists who can provide speech therapy when it comes to speaking difficulties, different strategies there, different communication mechanisms and aids for helping people when they can't speak well. And when it comes to swallowing disorders, there again, no specific medications. However, we can do assessments such as what I've shown in the picture there. That's swallowing barium and getting an x-ray or some imaging, allowing us to see how swallowing looks. And if there is dysfunction, we can identify it, and the speech therapist can then make recommendations on strategies surrounding swallowing, or even foods to avoid or ways to make it easier to swallow. And also tremor can occur in multiple sclerosis, and this is a rapid shaking back and forth around a joint or a fixed point. And this is something that can happen in different parts of the body, the head, the hands, the arms, for example. Sometimes adaptive equipment can be helpful. Other times even bracing helps. There are medications that can be useful to suppress tremors. Often they don't go away completely, but they can be subdued. And once again, Botox or botulinum toxin, depending on what the tremor looks like, this might be a useful treatment, actually injecting the muscles that are involved in the tremor to slow them down, to weaken those muscles might be a helpful way to go when it comes to certain kinds of tremor. Next, I'd like to pivot to the emotional and cognitive domain. And in this domain, we've got several things listed: anxiety, cognitive changes, depression, and something called pseudobulbar affect, or PBA. Let's start first with anxiety. Sometimes anxiety is overlooked. It may be one of the most taxing and undertreated psychological effects of people who are living with MS. And it can be written off as, oh, you know, they just worry a lot, or they anticipate appointments and get worried about them. But in fact, this could cause some degree of suffering, especially if it's not recognized and treated. So this is something else we like to pay a lot of attention to. And again, we don't have to jump to medications. When dealing with anxiety, we can consider psychotherapy, talk therapy, relaxation techniques, mindfulness, stress reduction techniques. And then if those things aren't helpful, certainly we can consider medication. There are a variety of medications that can help tone down anxiety. When it comes to brain disease, what we're dealing with in the end really are a lot of brain chemicals that may be, so to speak, out of whack. And getting them back into balance might, in fact, require some medication to help with that, especially in anxiety. Depression can occur in MS and some other of our brain diseases. Dysthymia is one form of depression. It's sort of a chronic state of a depressive disorder where there's a loss of interest in things, a loss of motivation perhaps, a loss of even energy can be part of that. So it's kind of hard to tease out what's fatigue versus what's part of a low mood and depression. So there's a dysthymia aspect, or there is a major depressive disorder. And sometimes a psychiatrist is necessary to tease these out, but not always. Sometimes these are situational. You know, if there's a strained family relationship in the mix, that can contribute to low mood. Sometimes depression itself can then lead to strained family relationships. People might find themselves socially withdrawing or having trouble at work with job strain or even job loss. That can contribute or cause depression. So we ask patients about what's going on in their life to get a better handle on things. And once again, psychotherapy might be an option, and there are a variety of medications that can be tried as well that often help both depression and anxiety. And before I move on to cognitive changes, just to touch briefly on pseudobulbar affect, or PBA. This can occur in MS. Somewhere around 10% is what I last read. This is a problem where people might have sudden onset of inappropriate laughing or crying, almost like an attack of emotion that's just not appropriate in that situation. And they don't feel inclined to laugh or cry, whatever it is, but it's just happening to them. And that can happen in MS and a few other neurologic diseases. And there is one medication that's on the market for that. It's called, it's a combination of dextromethorphan and quinidine. It's called Nuedexta, and It has variable benefits, but sometimes if we're not able to otherwise treat it and it's bothersome to someone, then we might consider treating it with that medication. Moving on to cognitive changes. Cognitive changes are quite common in MS, and as Dr. Gross highlighted, there's a lot of changes happening in the brain, whether it's inflammation and lesions forming or just overall shrinkage of the brain and cell death. All of these can contribute to cognitive changes. The most common symptoms that people experience are three things, really. Speed of information processing, having a hard time processing things quickly, for example, maybe not following in a movie or a story that you're trying to pay attention to, having a hard time processing new information, trouble with memory, and trouble with executive functions. And executive functions, just briefly to review, are things like planning, attention, strategizing, organizing, and paying attention to details. Causes of cognitive trouble, certainly, as I said, can be part of multiple sclerosis, but can also secondarily be due to the medication, side effects of medications that we've tried. Lack of sleep, if sleep isn't good, that can contribute to poor memory or slow processing speed. Depression can cause cognitive changes or make it seem that way. Untreated anxiety, stress, fatigue, all of these things can contribute to cognitive changes. So when somebody comes to us presenting and saying that they're having trouble with their thinking and memory, we really need to explore all of these other possibilities and not just be quick to say, well, it's just the MS. So there's a lot of questions that we like to ask around that. Once again, instead of medication right away, we can consider behavior modification techniques, cognitive training programs. Sometimes there's been thought that certain disease-modifying therapies may have some benefit to cognition. And then lastly, there's a few medications that can be considered for cognitive complaints with mixed results. And lastly, I'd like to focus on this last domain, which I'm calling the invisible type of symptoms: dizziness, fatigue, numbness, pain, sleep issues, visual disorders, weakness, and so forth. I'm just going to highlight pain in this last subsection because I could get really carried away talking about a lot of things. But pain being such a common complaint and such having such a major impact on quality of life is something I'd like to bring up. And when it comes to pain, people might say, oh, I have pain. And we assume that that means physical pain. But pain, as we know, can be a lot more than just physical pain. And this is why we like to approach it from our clinic in the team setting. So there's certainly physical distress, but there's also social distress, emotional distress, and sometimes existential or spiritual distress. And so trying to tease out what's what and recognizing that pain is rarely just physical is important if we really want to make an aggressive impact on treating pain. We've found that pain correlates to depression and involvement of the spinal cord. In other words, people with either or both of those things are more likely to report pain. And when we see someone with pain, we like to ask a variety of questions, not just, where does it hurt and how much, but, what does this pain mean to you? How is it impacting your life? How do you make sense of it? What would you do differently if you didn't have this pain? And to really get at it from a few directions, again, thinking about the impact that the pain is having, and then coming up with an action plan on how to proceed, thinking not just about the physical symptoms, but the other impacts that the pain makes. So when it comes to pain in MS, patients can have dysesthesias, or sort of abnormal feelings that aren't necessarily what you'd typically consider as pain. It can be aching or burning. Trigeminal neuralgia can occur. This is a facial kind of pain with the cranial nerve 5, the nerve coming out of the base of the brain, that can lead to usually one-sided facial pain that can be jolt-like, electric, and so forth. Lhermitte's sign is a kind of pain where sometimes if people with MS flex their neck forward, they might develop a shooting pain down their back and neck. And then there's a variety of other kinds of pain, back and musculoskeletal pains, muscle spasms, and so forth. So you see there's a variety of reasons why people with MS can have pain, different kinds of pain, and it can affect them differently. So a lot of ways to attack pain symptomatically. Certainly heat, massage, ultrasound would be conservative ways. Thinking about a soft neck collar or a brace if there is a tendency towards Lhermitte's sign or neck pain. Complementary and alternative medicine may have a role, whether it's energy therapies and acupuncture, et cetera. And then the category of medications. We can be really precise in the way we try and address pain depending on where it's coming from and the character of the pain. Sometimes antidepressants can be used to help pain. Anti-seizure drugs can be used, particularly in things like trigeminal neuralgia. Anti-spasticity drugs, not to forget Tylenol and nonsteroidal anti-inflammatory drugs like ibuprofen. Botulinum toxin, once again, might be helpful in the treatment of pain because of spasticity or tight muscles. And then opioids. Opioids may be necessary if everything else has been tried and the pain is just not responding to physical pain. And there are some surgical interventions for people with really bad pain that is just not touched by the traditional medications and other measures. And we have surgical interventional physicians that can help with potential interventions there. So in summary, I'd like to say, MS can affect certainly a variety of daily activities. As you're well aware, it can affect autonomy and quality of life. And people define quality of life differently, and people's priorities are different, but we like to explore those things in our visits and try and understand what's important to our patients and their families. Palliative care, once again, hopefully I've demystified it at least a little bit. It aims to improve the quality of life of both patients and their families, integrating the psychological and spiritual aspects into care, focusing on complex symptom management aggressively, and remembering that palliative care is really also meant to be an extra layer of support, like the cloak that I mentioned in the beginning. So thank you very much for your attention.
Thank you so much, Dr. Gross and Dr. Vaughn. For those of you watching live, if you have a question to submit, please do so now using the chat window on your screen. I'm going to start us off with a few questions that were submitted at registration. So we had a couple of questions that were asked about dementia, including is there an increased risk of dementia for someone with MS? And also just addressing the topic of worsening dementia and how the family might be struggling with independence versus safety.
So is there an increased risk of dementia with MS? Well, certainly, as Dr. Vaughn mentioned it, cognitive complaints, thinking problems are quite common in MS, and they range from the mild to the more severe. At the more severe end, it is appropriate to say that some people can have dementia. I think the word sometimes confuses people because a lot of times when people say dementia, they're thinking in their head Alzheimer's dementia, which is the most common form of dementia, but not the only form of dementia. MS can cause dementia. TBI, or traumatic brain injury, can cause dementia. Other neurodegenerative diseases, lots of things can cause dementia, which really just means you're impacted by cognitive impairment to such a degree that it's affecting your ability to kind of deal with life on your own, and you're going to need more help from others. And so that can certainly happen with MS, yes. Did you want to add something about the kind of how
Sure.
people deal with it, the family members in particular?
Sure. As far as how to deal with people with cognitive trouble, we received a few questions kind of along those lines. I think one of the benefits of having a team approach to these visits is that we can really kind of dig in with how cognitive trouble is affecting the family as well, and think through some strategies on how to deal with these things, workarounds perhaps, trying to think through, reminders, ways to remember to take medication, whether it's alarms or special pill boxes, things that can be impacted by cognitive trouble or cognitive decline, and actually talking through it and not treating it like the elephant in the room. If somebody's typically been handling the finances and are really struggling cognitively, then we need to be frank and gentle and say, we've got to think about alternative ways maybe take on that role or to pass that role on to someone else, and to think about planning for the future with regard to, who's going to manage the finances if that becomes a problem. So to kind of just be real about these problems and strategize. I think that's what we do in our visits, as well as try and support the family and answer as many questions and try and normalize what's going on.
So we also had a question wondering how a patient can tell whether it's old age or worsening of symptoms.
This is kind of funny, because I'll sometimes get patients who ask me, is it my MS or is it old age, and they'll be like 40, and I'll say, wait a minute, you're not old. But certainly sometimes it can be hard. As people get older, just with normal aging, we'll see some things like a little forgetfulness here or there. So sometimes it can be difficult to tell, and that's why it's important to have these discussions with your doctor, with your team, and to try to see if they can help tease it out. And sometimes the one way of figuring out what the cognitive troubles are and the extent of it is by undergoing what's called neuropsychological testing, which is kind of more comprehensive and longer than the kind of testing that you would typically get in an office setting with your neurologist. It's usually several hours, and they go over all the different kind of domains of cognition, so like memory and executive function and learning and so forth. And they can really kind of pinpoint where the deficits are in relation to kind of how you would be expected to be functioning. And so that can be helpful in trying to tease that out.
I would say in the same vein, we've got a question about the differences and similarities between primary progressive MS and secondary progressive MS.
So to me, progressive MS is all one disease. In fact, MS is all one disease. It's just that depending on what phase you're in, and then what could potentially be going on, on a cellular basis. But I think it's all one disease. And when we talk about the difference between primary and secondary progressive MS, really all that means is in primary progressive MS, you have this kind of insidious decline from the beginning, and then in secondary progressive MS, that deterioration happens after an initial course of relapsing remitting disease. So you have the relapsing remitting disease first, and then at some point down the line, typically after 15, 20, 25 years, you slowly transition to this secondary progressive phase. Now, the one difference I will say in terms of how these present is that because primary progressive doesn't have that initial relapsing course, we tend to diagnose it at a younger age. So, when people are in their kind of 30s, 40s, whereas people with secondary progressive MS, they will often have had the diagnosis of relapsing remitting MS first, and they won't transition to the secondary progressive phase until usually they're kind of late 40s, 50s, kind of even 60s kind of thing. So the age can be a little bit different, but that's kind of it in terms of the underlying why it happens. I think it's pretty much the same thing, and for that reason, I think that it's likely that the medications people will respond to the same medicines in either the primary progressive or the secondary progressive MS phase, or they won't respond. But I think that saying, because you have secondary progressive MS, you won't respond to this medication, but if you had primary progressive MS, you would, I think that's a little bit misleading. In fact, the thing that really corresponds most closely with how well somebody is going to be, how responsive somebody will be to treatment is whether how old they are and how long they've had the disease. So if somebody's had MS for 40, 45 years, what have you, doesn't really matter what phase they're in. It's unlikely that our current immunotherapies are really going to be beneficial versus if they're much earlier on in the disease process, they're much more likely to benefit from our treatments, from our immune treatments.
We also had a question regarding some of the issues that a caregiver faces in helping someone with primary progressive MS who's wheelchair bound, specifically pain from sitting in the same spot or pressure sores.
That's a great question. I think when someone is really restricted to relying just on a wheelchair, it can feel limiting, certainly, and there's accommodations that can be made to deal with that. So we talk through that, the practical side of things, you know. What's your home like? Are the doorways wide enough? Is the bathroom door wide enough? Things like this. And thinking about workarounds, you know, if that person still wants to cook, thinking that, you know, making sure that their appliances are at a reachable level if they're in a wheelchair. When it comes to pain from sustained sitting for too long in one position, we really like to remind people that they need to shift. So if they're seated all the time, to think about, you know, leaning on one side of their bottom for a period of time and then the other, having egg crates or various things. You know, we actually consult occupational therapists, for example, to guide us on different things to put on the wheelchair, in the wheelchair, to make it more comfortable, to help with pain. Certainly we want to address the pain and not ignore it. So we want to think about topical pain medications that can be used, like salves and things that are sometimes even prescription strengths. And we want to think about other ways. But certainly what we'd rather do is avoid or prevent the pain from starting in the first place, and certainly prevent skin breakdown, which can happen if somebody sits for too long in the same position, which can result in pressure sores. Once pressure sores develop, then we bring in a wound care team or a wound care nurse to the home or wherever the patient is to try and help that heal, which can take some time, but cared for properly, often those are treatable. And again, we don't want to ignore the pain. We want to do whatever we can to help minimize and make it go away.
We very, very briefly touched on some alternative possibilities. We do have a question regarding any sort of marijuana that is available in a medical scenario. I think particularly for spasticity and pain relief.
So we're in Colorado, so first disclaimer, where cannabis is a lot more readily available and medical cannabis is certainly easy to come by. Unfortunately, there still remains a lot of unknowns, a lot of questions unanswered when it comes to using medical cannabis for neurologic disease. The most benefit I've had in my anecdotal experience has been with nerve-related pain or neuropathic pain, not taking it away certainly, but helping it become more manageable with medical cannabis, help with insomnia, sometimes help with anxiety, and for people who have poor appetite, sometimes it can help certainly trigger appetite. Those are among the most common or among the symptoms that have had the most benefit in my experience. We try and minimize the THC component in medical cannabis or start just with CBD, cannabidiol, because the THC part is the part that causes the high. When people are recreationally using cannabis, THC causes the high, and so we don't want to make new symptoms or cause confusion or anything else. So I like to start just with CBD if I am going to go down that road. I don't automatically start with CBD or cannabis in treatment of things like neuropathic pain. I try other measures first, but sometimes things aren't working. I want to try that as well. I'm open to it. Do you have any experience to speak of there or to add?
Well, I thought that was, I pretty much 100% agree with what you just said. It's, you know, we'd like to have more of the kind of, you know, really high-level evidence to support its use, but that you know, that hasn't really been, we haven't been able to do the kinds of studies that we'd like to do with it. So we mostly rely on, like our anecdotal experience and what you tell us when you go out and try it and you say that it's helpful. And so I've also found that my patients will tell me that their pain is improved, that their sleeping is improved. Spasticity is another one that sometimes people will find that the marijuana or CBD products can be helpful for. But it's an area that we definitely would like to learn more about.
In the interest of time, I'm going to kind of combine a couple questions here. I think that they're about the experience of a palliative team, wondering what can be expected when a palliative team comes into the home for interventions, And then also we had a question from someone who says, if you're severely disabled and have difficulty getting to and from multiple appointments, how can you maybe access palliative care?
These are great questions. Some of it depends on where you're living geographically. So one thing that exists is home-based or community-based palliative care. And again, this really depends on your region, but what this could look like is a team of folks led by usually a nurse or a nurse practitioner, also including a social worker, a spiritual care counselor, sometimes nurses' aides. They don't come very often. It's the same sort of setup, though for different time in life, as a hospice team, though it's reserved for people who are not at the end of life. They just don't come as frequently as a hospice team, and so that varies too. They might come once a month, and you might have access to them over the phone. They might come every couple of months. It just really depends. And so these types of organizations do exist, palliative care in the community. It just depends where you live. For our clinic, for example, it's strictly here on the campus in the university setting, so people would have to come and see us. We are working, as are other places, on creating a telemedicine option so that people who are just not able to come, either due to disability or distance, are able to see us virtually over telemedicine, over the internet, something like Skype. That's not yet in place here, but plans are underway, and this exists, I think, in some other places already. Did I miss a piece to that question?
I think so.
I'll add that we are also trying to, in our clinic, in the MS clinic, trying to get telemedicine or telehealth a bit up and running. So stay tuned for, hopefully that will be soon. And actually, we already have a little bit of it up and running, but yeah, it will be expanded.
So in the context of sexual dysfunction, has ED medications such as Viagra been used or made available to MS patients?
Yes, absolutely. It's a medicine that I will prescribe commonly. It is an expensive medicine, I've seen, and sometimes the insurance companies might not approve it. So there's some things that we can do there, but yes, and as far as the medical part of it goes, yes, absolutely, it's something that we will prescribe and is helpful to people.
Yeah, we encourage patients to bring up all sorts of issues, including these of sexual dysfunction. Often they're overlooked, and so if your physician or care team hasn't asked you and that is an issue, you should feel comfortable to bring that up, and we can consider prescribing one of these medications, yes.
Are there any drugs that would help improve primary progressive MS?
It depends on what you mean by improve. I think that, as I talked about with ocrelizumab, it does appear to slow the progression down, particularly in a younger, still ambulatory, still walking population of progressive MS patients. But there are plenty of other things that can improve, quote unquote, the disease, which is, like we were talking about, if the person has mobility problems, if they have pain, if they have spasticity, all of these symptoms are amenable to treatment with whatever medication or other intervention we have, and that people do sense an improvement in that. So I hope that answered the question.
Yeah. So I am going to cut off the questions now because we are out of time. I will say there were a couple of questions regarding DMTs and exercise. We do have quite a few resources on our website, including webinars on both exercise and DMTs and presentations from our previous Ed Summits, again, both on exercise and DMTs. If you would like me to send you those resources, I can find the exact ones you're looking for. You can just email me, education@mscenter.org, and I would be happy to help you out. Thank you, Dr. Gross and Dr. Vaughn, for your time today and sharing all of this knowledge.
You're very welcome.
Thank you.